The next topic we're going to take on is anxiety disorders. But I've broken these videos up into 3 parts. Part 1 will provide an overview of anxiety disorders and also talk about the symptoms, epidemiology, etiology, and treatment of specific phobias. In the second video, we'll cover panic disorder, and in the last video, we'll cover agoraphobia and generalized anxiety disorder. So let's go ahead and get started. Before we dive into the symptoms, though, it's important that we clarify just what we're talking about when we say anxiety, because there are a lot of misunderstandings about it. So first of all, it's important to recognize that fear and anxiety are not the same thing, because in many cases, fear can be quite adaptive. It can signal when situations are unsafe, it can help us remain vigilant, and because of how fear affects our autonomic nervous system, it can allow us to be physically prepared to fight or to flee. So fear in and of itself isn't the problem, but excessive fear, which impairs functioning, or what we might call anxiety, can be problematic. So let's turn to some general considerations relevant to anxiety. First, symptoms of anxiety often start relatively early in life, typically by the teens or the early 20s, and there are a number of reasons why this might be, including the fact that evolutionarily speaking, people are more vulnerable when they're younger. They have fewer defenses, for example, so that could be a carryover. Younger people are also more highly influenced by caretakers, so if our caretakers are modeling anxious responses, we may be more likely to learn those. Finally, younger people also have underdeveloped coping skills because they haven't had enough experience to figure out that they can cope or how they could best cope. Second, anxiety disorders are diagnosed twice as often in women as they are in men. Again, there are any number of reasons why this might be the case, including underreporting by males. There may be biological differences that make women more susceptible, or again, evolutionarily, women may be more prone than men to experience fear and anxiety in order to remove them from harmful and dangerous situations. Finally, anxiety, like many other disorders, have a waxing and waning course over the lifetime, meaning that the symptoms come and go throughout our lifetime. So people with anxiety disorders aren't always anxious all of the time. But symptoms do typically remediate substantially as people age, so the proportion of people over the age of 65 with an anxiety disorder is fairly low. One other important consideration, before we get into the diagnostic criteria, is that anxiety symptoms may be due to one of the primary anxiety disorders, which include separation anxiety, selective mutism, specific phobias, social anxiety disorder, panic disorder, generalized anxiety disorder, and agoraphobia. Or anxiety could be secondary to substance abuse, which we would call substance-induced anxiety disorder, a medical condition, which we would call anxiety disorder due to a general medical condition, another psychiatric condition, or psychosocial stressors, which we might diagnose as adjustment disorder with anxiety. For the sake of this class, the disorders you should be familiar with include specific phobias, panic disorder, agoraphobia, and generalized anxiety disorder. So let's dive in and first talk about specific phobias. The diagnostic criteria for specific phobias may feel a bit daunting at first, but we'll go through them step by step. So the first piece is marked fear or anxiety about a specific object or situation. The feared object or situation can be virtually anything, but there are some that are more common than others, and also some that are also quite interesting. So, some particularly common or interesting stimuli that elicit phobias include snakes, which we call ophidiophobia. Blood itself is called hematophobia, or trypanophobia if the fear is about the needles or giving blood. Fear of elevators doesn't have a specific name, though claustrophobia is about fear of small spaces. Agoraphobia, which is fear of high places, and one of the most interesting ones, I think, is coulrophobia, which is fear of clowns. Although there's considerable diversity in what can serve as the targets of phobias, they do tend to cluster around one of several categories. As a result, the DSM-5 phobias are specified as falling into one of 5 groups: animals, the natural environment, blood, injection or injury, situational, or other, which is a catch-all category. The next diagnostic criteria for specific phobia is that the phobic object or situation almost always provokes immediate fear or anxiety. meaning that when the person is exposed to the feared object or situation, anxiety symptoms will result. And we can think of these symptoms as falling into one of three categories: physiological symptoms, emotional or psychological symptoms, and behavioral symptoms. Physiological symptoms can involve things like rapid or irregular heartbeat and breathing, palmar sweating, dry mouth, dilated pupils, and muscular trembling. Emotional and psychological symptoms might be a sense of worry or concern or apprehension, a sense of fright, dread, or terror, and an inability to concentrate. And behavioral symptoms might include flight or disorganized speech, and motor incoordination. In an effort to avoid these symptoms, the person then actively avoids the feared object, or if unable to avoid, endures being around the feared object or situation with intense fear or anxiety. Next, the diagnostic criteria for specific phobias stipulates that the fear or anxiety is out of proportion to the actual danger posed by the feared object. And this is a really important piece of the diagnostic criteria, because if the feared object is actually extremely dangerous, then it's frankly adaptable to be extremely afraid or anxious about encountering it. So in the case that the feared object actually is dangerous, then we wouldn't categorize the symptoms as a specific phobia. It's only in those circumstances, when the fear or anxiety is out of proportion to the actual danger posed, that a diagnosis of specific phobia becomes appropriate. Next, that the fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. And finally, that the fear, anxiety, or avoidance causes clinically significant distress or impairment in functioning. In terms of the epidemiology, or the incidence of specific phobias, most recent data suggests that about 15% of the U.S. population meets diagnostic criteria for a specific phobia. That doesn't mean that 15% of the population has a diagnosis of specific phobia, but just that they could meet diagnostic criteria. As is the case with most types of anxiety disorders, the onset is typically earlier in life, and women are about twice as likely as men to have symptoms. Regarding the etiology, or causes, of specific phobias, research has provided the most support for two different theories. First, there's some evidence that genetics may play a role in specific phobias, with specific phobias running in families. However, learning has also been shown to play a role. As we've talked about in class before, the two-factor theory has been used to explain the development of specific phobias, with phobias first being conditioned by linking an anxious reaction to an otherwise benign stimuli, and then, because the person begins avoiding the feared object or situation, the person does not experience the anxiety, which ends up reinforcing the avoidance behavior, and therefore the phobia. Finally, in terms of treatment for specific phobias, two primary approaches have gained the most support. The first is exposure therapy, in which the individual is literally exposed to the feared object or situation so the person can unlearn the anxious reaction. This typically happens in stages, and we'll look at an example of this in class. The second is systematic desensitization, in which relaxation training is paired with exposure to gradually desensitize the person to the feared object or situation. The steps to systematic desensitization include, first, teaching the clients relaxation techniques, next, creating an anxiety hierarchy with the client, and an anxiety hierarchy is a ranked list of exposures to the feared stimuli or object from least anxiety-provoking to most anxiety-provoking. So, for example, if a person had a fear of dogs, the least anxiety-provoking exposure might involve reading a book about a friendly dog, then followed by looking at a picture of a friendly dog, followed by watching a movie about a friendly dog, followed by watching a dog walk past a window, followed by being outside with the dog that's 50 feet away, etc., etc. And then finally, you put the two pieces together. So you gradually expose the client to each step of the anxiety hierarchy, while also encouraging them to use the relaxation techniques if the anxiety arises. And clients step up or move on to the next, more anxiety-provoking stimuli only when they're able to be exposed to the previous stimuli without feeling an appreciable increase in anxiety. So that's specific phobia. In the next video, we'll move on to panic disorders.